Okay, we'll go ahead and begin our session. Again, thank you, everyone. I am Allison Caban-Holt, and I am the chair of the Recruitment and Retention Committee. And this is our Take Action series. And this Take Action, we're going to be focused on enhancing community engagement in clinical research. And our objectives today are to help with understanding your community and building trust, normalizing clinical trials as the best treatment option for certain cancers, meaningful engagement of underserved and underrepresented patients, and identifying evidence-based practical as well as practical strategies for community engagement. So we have a great panel today who will be sharing their experience with regard to engaging communities. But before we get started, we are, did you want to do anything else with the word cloud? Yeah. So thank you for sharing with the word cloud for us. It looks like equity is one of the main reasons for that we feel is important for including underrepresented populations in clinical research. So I'm going to just have a few slides about the Recruitment and Retention Committee, and then we will have our panelists begin their presentations. So the Recruitment and Retention Committee, our mission is reflective of one of SWOG's guiding principles, and that's having diverse participants in clinical trials as well as in the membership and leadership of SWOG. And there's a special focus on health disparities and underrepresented populations in our committee. We advise research teams on effective strategies for recruiting and retaining diverse groups of patients onto SWOG trials. And we had mentioned this at the last meeting, and hopefully you're aware of this resource. So we have a recruitment and retention assistance request form. So any trials study teams, if you want to engage with the RRC and request assistance about how do I, what are some of the ways that we can attract or find particular groups of participants for your trials, please reach out and use that request form. And if it's time sensitive, use the email address of recruitment@swog.org because we know that sometimes there are very time sensitive sorts of issues. But if you want to engage with the RRC in particular, please use this request form. Here's a couple of screenshots of it. It's not very long and detailed, but it gives us a chance to reach out to you and find out more about what your needs are for your trial. Our Take Action, which we're doing today, was developed by Kamara Mertz-Rivera and Lucy Gansauer, who are both members of the RRC as well as education are part of our education committee. So far, our Take Action series has included looking at focusing on African Americans, Asian Americans, American Indian populations, Latino Hispanics, and our last one in the spring was reducing structural barriers to clinical trials recruitment. And so today we are looking at community outreach. Enhancing community engagement in clinical research, again, those are our objectives. So we have a great panel who will be sharing with us today. And they're going to be introduced in a minute. What I did want to say is for those of you who are attending virtually, we will ask you to put your questions in the chat, and we're going to be monitoring the chat questions. And we also ask those of you who are here with us in person to hold your questions till the end, and then we will do a big Q&A. So write them down, keep track of them, but we'll try to keep the Q&A at the end. Here are our speakers. They're going to be introduced in just a minute. So we do have some additional questions that we will want you to respond to using the poll EV. So you can see that you can text SWOG 2023 to 22333 and or join by web using the pollev.com/SWOG 2023 and respond to those questions.
So we can go ahead and answer the question. We can go ahead to the question.
Okay. Do you want to? And now Kamara Mertz-Rivera will be introducing the questions.
Thank you, Allison. My name is Kamara Mertz-Rivera. I am the administrator for Upstate Carolina NCORE and the administrator director of research at the Gibbs Cancer Center located in Spartanburg, South Carolina. And I'm really excited to be here, and I'm super eager to hear all about shared experience from our experts here and our panelists. First, I would love to have everyone, they've already started. That most people online, I appreciate your response, but if you could go ahead and answer the question that's posted, which is what communication channels or methods does your research site use to better inform the community about clinical research opportunities? And you can select 1, 2, 3, all that apply. And we'll just give it a moment for people to participate. So it looks like so far, if I'm not mistaken, it looks partnering with healthcare providers and social media platforms seems to be leading. Great. Okay, I think we have one more question for you. What are the main barriers that might prevent underrepresented populations from participating in clinical research at your site? And the options are a lack of awareness about research studies, concerns about the safety of research participation, difficulty in assessing site transportation issues, trust, and other. Looks like we have a leader of lack of awareness about research studies. And again, you can select all that apply. All right, looks like lack of awareness about research studies, and that is actually a perfect segue to talk a little bit about why it is so important to have underrepresented patients participate in research and maybe some solutions that you can apply at your site. So we're going to go ahead and move forward, and I'd like to introduce Lynn Nguyen. She is the Associate Director for Research Planning and Development in the Center of Community Engaged Translational Research at MD Anderson Cancer Center. And she leads MD Anderson's efforts to increase diversity in cancer clinical trials. So welcome, Lynn.
Thank you. Good afternoon, everyone. I apologize in advance for my voice, but it actually sounds much better today than it did 2 days ago. So at MD Anderson, I lead a team of engagement specialists to promote clinical trial awareness and support to the public, and to facilitate long-term equitable research partnerships between our researchers and community-based health and human services organizations. And I was thinking about, when I was asked to speak on this topic, I was thinking about what questions you might have and what you might be interested in. And I thought that you might be wondering whether physician scientists have a role in engaging with communities about research. I mean, aren't others already doing that, but they're paid to do that in your organizations or other groups that are doing that? And maybe you remind yourself that you're already impossibly overcommitted doing research and serving patients. And maybe one of those commitments that you've overcommitted to is to give a talk to the community about the latest research for that particular cancer that you work in. But is there a role for you beyond an annual talk to a community group? And how important is that role? So I hope that at the end of my presentation, you will not only recognize the vital role that we all have in shaping community perspectives, and understanding and support of clinical research. And I also hope that you walk away with a solid grasp of the foundational principles of community engagement and why engaging with diverse communities is a vital component of the research enterprise. So any talk about inclusive, meaningful clinical trial participation must include a discussion about population demographics. An understanding of population demographics will prepare us to visualize the communities that we need to engage to promote diverse participation. The U.S. Census has projected that the U.S. will continue to evolve into a more racially and ethnically pluralistic society. In 2000, if you look at that first picture, the U.S. population was 281 million, of which 69% were non-Hispanic white. 20 years later, in 2020, the proportion of non-Hispanic whites had dropped to 60%. And it's not that there was a decrease in the actual total numbers in the white population. It's just that the other groups have grown so much more. So between 2010 and 2020, racial and ethnic minorities accounted for almost all of the U.S. population growth and were responsible for population gains in many states, metropolitan areas, and counties that would otherwise have registered losses due to declines in the white population. Most noteworthy is the increased diversity in the younger proportion of the population. In 2020, for the first time, more than half of the U.S. population under age 16 identified as a member of an ethnic minority group. And among this group, Hispanic and African American residents together comprise nearly 40% of the population. But wait, there's more. 2020 marks a turning point for the U.S. population because it's a demographic turning point for the U.S. Beginning that year, all baby boomers will be older than 65. And some of you may be aware of generational demographics, but the baby boomers is the largest population demographic in the history of the United States. At its height, it was 78 million strong. And as you can imagine, as this group moved through the years, they changed everything. They changed from where schools were built, from what types of jobs flourished, where people expanded to. And now the statistic is that 10,000 people turn 65 every day. And that's the baby boomer generation. But by 2030, all of the baby boomers will be older than 65, and baby boomers are those born between 1946 and 1964. And the nation's 65 and older population is projected to nearly double in size in the coming decades, from 49 million in 2016 to 95 million in 2060. So as a result, the share of people aged 65 and older will grow from about 15% of the population in 2016 to about a quarter of the population in 2060. That means 1 in 5 Americans, a little bit more than 1 in 5, is projected to be retirement age. And the number of people 85 and older is expected to nearly double by 2035 and triple by 2060. So by 2060, about 19 million will be older than 85. And by 2034, older adults will outnumber children for the first time in the US. And as the population ages, the number of deaths is expected to increase substantially. And one of the reasons, of course, is cancer is the higher your age, the higher your risk. So even as we see the cancer rates drop, we will actually see more cancer cases. Hospitals will be building more and expanding because the numbers of cases will rise exponentially. So it's really important to be able to kind of visualize this population that we will be seeing, and how do we engage with them? So the research implications. We know that certain groups in the US experience cancer disparities because they are more likely to encounter obstacles in getting healthcare. For example, people with low incomes or low health literacy, who have to travel long distances to screening sites, or who lack health insurance, transportation, etc., or medical leave, or are less likely to receive recommended cancer screening and to be treated according to guidelines than those who don't have these obstacles. And people who do not have reliable access to healthcare are also more likely to be diagnosed with late-stage cancer, and that might have been treated more effectively, and you know this. And we also know that some groups are disproportionately affected by cancer due to environmental conditions. People who live in communities that lack clean air or clean water maybe have more exposure to cancer-causing substances. So advances in cancer prevention and treatment are built on clinical trials. And I just had to include this lovely chart by Joe Unger, and it shows the absolute percentage increase in 5-year survival for each age group. And of course, you see the green line at the top, the youngest age group, and they had the biggest increases, percentage, because they have the highest participation rate in clinical trials. So we know all of this, but what do the public think about clinical trials? Well, the Center for Information and Study on Clinical Research and Participation, CISCRP, conducts a global study on the public and patients' perception of research every 2 years. The latest study results showed that among people who had never participated in research, the proportion of respondents who said that they understand the term clinical research study or clinical trial very well dropped from 40% in 2019 to 31% in 2021. And actually, that is a significant drop. And if you can imagine, this all happened during the pandemic years when we were inundated with information about clinical trials for vaccines. And it was interesting because Black and white respondents were more likely to say they understood the term clinical research study well or very well compared to Asian respondents. And as we remember, there was actually a lot more ads targeted to Hispanics and African Americans because those were the groups that had significant disparities. Excuse me. So they also had this really nice data on the pandemic's impact on clinical trial awareness. And most respondents feel that the pandemic has made them more aware of clinical research studies, with awareness higher among underrepresented communities. Hispanics were more likely to report greatly increased awareness compared to non-Hispanic, and Black respondents were more likely to report greatly increased awareness compared to white and Asian respondents. And the interesting thing is John Miller, in a report for the American Academy of Arts and Sciences, wrote that only 28% of American adults have sufficient understanding of basic scientific principles to be able to read the science section in the New York Times, 28%. And some research further suggests that this percentage might be substantially lower when citizens are faced with strong advocates on opposing sides. So you can kind of see why people might feel that they don't really understand what this term means. At the same time, we have to realize that most adults will acquire most of their scientific information after they leave formal schooling. Because how many current adults today can claim that they actually studied stem cells or immunotherapy when they were students in school? So we're all learning this by the media and all of these sources around us. So it comes to, then why do we engage with communities? We engage with communities to increase participation of individuals in our catchment area, particularly minorities and women, and so that diverse groups can feel heard and acknowledged, to facilitate bi-directional relationships, not just one-sided outreach, to cultivate community support for our research goals. And when the community is empowered to share their lived experiences and contribute to research, it helps to make research more patient-centered and relevant to the participants. So how we talk about research, with whom we engage, and how we engage is key to advancing our community's understanding, support, and trust in research, and ultimately to their willingness to participate in research. And I want to add that this engagement, we're going for the long-term picture. We're not saying that by you going out one time or two times is going to change, because obviously they have to have cancer, but they might not have cancer now. They may later, or they may be advising families and friends who have cancer. So all of this will add to that momentum that we build. So here are the guiding principles for engaging with communities about research. First is planning and preparation. It's not rocket science, but it's really important. It must be done. We've got to develop community engagement goals and identify appropriate approaches in the early design phase. We want to think about the purposes or goals of our engagement effort and the populations or the communities that we want to engage with. Early engagement with a population that has the experiential knowledge of that health condition will enhance the likelihood of your successful study accrual. And what you want to do is you want to leverage your personal and professional networks, the online communities, your social media, and we've got several people coming after me who will be talking about that. And you want to work with your organization's own community outreach, marketing, advertising, public education teams. The good thing is you don't have to do it by yourself, but you want to be a part of that team because you want the communities to know you, to see you, and to see your commitment. Inclusion and diversity. You want to equitably incorporate diverse people, voices, ideas, and information, To lay the groundwork for your recruitment success, awareness of the many facets of culture and diversity will help you to create more meaningful and compelling information for your audiences, and that your research will be infused with respect for cultural norms and values. So recognizing the importance of and understanding and respecting all of the cultural, historical, and social context of the community is really important. Collaboration and shared purpose. Engagement is based on community support and shared purpose. Go to the community, establish relationships, build trust, show up, seek commitment from your community partners, and give them commitment from you and your organization. Community feedback can inform our decisions and our research priorities, methods, and strategies. Openness to learning. Learning about the community's culture, the economic conditions, the social network, knowing that it might be very different from your own. The political and power structures even, the norms and values, demographic trends, history, even their experience with the engagement effort of other organizations like yours. Was that a positive experience or was it a bad experience? That is really important to know too. And just remember, when you're out there, both sides are learner and both sides have expertise. So we're not the only ones teaching, we're not the only ones learning, and we're not the only experts. So we learn by asking questions, not by telling people all the time. Asking questions help us to see the big picture, understand people's concerns, the barriers to care that they face, the situations that they're in. Then we can begin to share our ideas and knowledge that have been shaped by this additional information. And transparency and trust, to be clear and open about the purpose of your study, your role, who is funding your study. The information shared, written or oral, should be in plain language and include only what people need to know. Don't give too much information. Impact and action. Explain about the impact that participants can have on the research, the future of care, the potential to make a difference. Remember and accept that community self-determination is the responsibility and right of all people who comprise a community. Don't assume that you can bestow on a community the power to act in its own self-interest. And finally, continuity. This promotes a culture of participation with programs and institutions to support ongoing quality community engagement. You want to maintain an ongoing presence with your community partner. You might want to focus on one or two so you can devote more effort. And again, it's not just you working with your network, with your teams, but be a part of that team because your voice is a very powerful voice. And be someone that the partner can count on. Long-term presence is crucial to trust. Leverage all your connections. One example, your hospital might be sponsoring community events. You know, if you've picked your high priority partner that you want to keep building this trust and collaboration, you might want to support them by buying a table every year. So these kind of things really demonstrate commitment. They don't see us only when we want something. So in summary, thoughtful and intentional planning is key. Think about who else needs to be at the table. You want to tailor your information to the audience. You want to align the mission with that organization that you want to partner with. You want to get commitment from them on this aligned mission. And you want to give commitment also. It's got to be two-way. There are other experts in the room. It's always other experts, and there's always other learners. And transparency, honesty, integrity, and consistency are your trading cards. And we want to be in it to play the long game. And that is it for me.
So thank you, Lynn. And we're going to ask you to hold your questions till the end, and then we will have an opportunity to ask Lynn some questions in a little bit. Thank you.
So we're moving on to our digital engagement approaches, and we have 3 people that are going to join us. And I'm happy to introduce Dr. Lewis. He received his medical degree, completed his internal medicine residency, and served as chief resident at Baylor College of Medicine in Houston. After completing a hematology oncology fellowship in the Mayo Clinic in Rochester, Minnesota, where he served as chief fellow, he returned to Houston to work at the MD Anderson Cancer Center for 4 years with a dual appointment in general and gastrointestinal medical oncology. Before assuming the directorship of gastrointestinal oncology and Intermountain Healthcare in 2016, he serves on the board of directors of the Neuroendocrine Tumor Research Foundation and as vice president of American Multiple Endocrine Neoplasia Support. He has also chaired the SWOG digital engagement since spring 2023. So we're really excited to have you. And I'm going to go ahead and introduce Jonathan Summers and Frank DeSanto. Jonathan Summers is a cancer survivor and a patient advocate and filmmaker who works at Digital Health Networks as their chief patient advocate and director of originals. He's a longstanding member of SWOG's digital engagement, adolescent and young adult, and patient advocate committee. He spearheaded Digital Engagement's Cancer Briefs, a Hope Foundation sponsored pilot study with which evaluates social media infotainment as a tool to engage the public around cancer clinical trials. And last but not least, Frank DeSanto is communications and public relations manager for the SWOG Cancer Research Network. He has long worked in scientific, technical, and medical communications, including a previous stint at SWOG's communications manager, and he holds an MFA from the University of Michigan and a medical writer certification from the American Medical Writers Association. Take it away.
Thank you so much for the introduction and for the invitation. This is the farthest thing from an individual effort. This is truly team science, and honored to represent the DE committee here with my wonderful colleagues. So I think if you think about the overlap between what we're trying to do here, the Venn diagram engagement is right in the middle of this Take Action Symposium. So I wanted to address what's been happening over the last, say, 10 years in particular. And I think we've been living through a revolution, through a sea change, particularly in how our profession, meaning oncology, physician scientists involved in oncology, researchers, how we perceive social media. And this is how I look at it. I think the pendulum has swung from, on one end, this being viewed as entirely unprofessional and frivolous, to the middle point where it's viewed as acceptable and helpful, to now I would argue it's practically mandatory. And on the last point, you can say this is selection bias. I'm the chair of DE. Of course, I feel that way. But my sort of origin story in this space actually dates back to MD Anderson, one of my workplaces that I shared with Lynn. My very first day, I was out of fellowship, first faculty position, got called to the office of my chair. It was Dr. Mike Fish, who many of us know. And Mike said, "Mark, before you leave this office, I want you to sign up for Twitter." That was not what I was expecting. I thought I was going to be quizzed on chemo. I thought there was going to be some measure of my proficiency as an oncologist. But what Mike asked me to do that day has affected my career ever since. And he convinced me, he said, this is going to become, again, a near mandatory tool in how you approach oncology. And it's interesting, Mike wasn't even encouraging me to be active, in the sense he wasn't encouraging me to produce content. He was encouraging me to consume content at first. What he said was, there's so much information, there's so much to know. He said, you're going to be absolutely deluged. And he said, the first thing you need to do is use this to curate your media diet, if you will. And he was absolutely right. So rather than being completely overwhelmed by the torrent of new findings, which is a nice problem to have, Twitter in its initial incarnation allowed me to narrow that down into a refreshing and palatable stream. So that was my entry point. And I went home that night. My wife asked me, "How was your first day, honey? How was your first day at MD Anderson?" And I was like, "I have a Twitter account now," which was not what, again, either one of us expected. But again, it's been foundational for my entire career. So with that, and with Frank's expertise as our communication and public relations manager, we've actually crafted a poll for all of you. So again, this is going to be interactive. I want to kind of literally read the room and take your temperature in regard to how you all use social media currently. So Frank, I'll turn this part over to you. We'll see how our audience engages.
Thank you. Yeah, we just want to get a clearer sense of what you as our members are doing with social media and what your sites are doing. Again, poll everywhere. You're probably already logged in by your cell phone. Okay, first two questions are about your site. So if your site does tweet, makes posts to Twitter, who's the intended audience? And answer as many as apply here. You need to send a separate text for each answer choice. Like a lot of sites don't use Twitter. Okay. A lot of sites don't use Twitter, and otherwise they're aiming for the general public, it looks like. So we will move on to the next question then. So if your site does use Twitter, what do you see as its goals in tweeting? Like sharing exciting clinical developments is a big one. Okay, we'll move on to the next question. The next two questions are about you yourself. If you use social media professionally, not to send pictures of your kids' games to grandma, which platforms do you use? And again, multiple answers are possible. Like LinkedIn is the big choice there. That's good. So we have plans to beef up our presence on LinkedIn, particularly for member engagement. So. Okay, one more question then. So if you do use social media professionally, what are your goals in using it? Okay, looks like reaching colleagues is the big one. And learning about new trials is not. Okay. Great. Well, thank you for your time.
So much
for you.
All right, so LinkedIn wins and engaging with your colleagues. Fascinating. That's exactly why we ask these questions, not what I would have guessed. So thank you for your responses. So now I want to shift gears and think about the, no offense to you guys, but the ultimate stakeholders who are the patients, of course. And I want to run you through a thought exercise, which at least for the advocates in the room is the farthest thing from hypothetical. Imagine that now in 2023, you are diagnosed with cancer. What would you feel? What would you do? So when I take a straw poll of my patients, they describe what I've termed the tinnitus of terror in their first visit with me. It doesn't matter how much I've prepared. Doesn't matter how cogent I think my explanations of cancer are. They literally hear that word, the big C, everything else becomes a low drum. And so a lot of their work, their processing happens after the appointment. And in the last couple of years, the term doing your own research has become somewhat pejorative, but I think here again, with their life on the line, literally, I think it's quite understandable. our patients are going to use digital tools. I want to say very briefly, I'm not blind to the fact as a DE chair that we actually have patients who literally can't engage digitally. I serve a rural frontier population. About half my patients live outside the metropolitan area. Some of my patients don't reliably have electricity, which means they don't reliably have internet either. With that said, among the patients who do have internet access, 97% of them, no surprise in the modern age, will search for information about cancer. And what tool will most of them use to do that? Google. So we might raise an eyebrow about Dr. Google, and I'll get to that in a minute, but it's prevalent for a reason. It indexes essentially all internet content. And of course, that's where our patients are going to go first. What do they get back? So there's a real trade-off, as I'll get to, in terms of, as was already mentioned, scientific literacy here. So the most accurate information that they get concerns etiology and symptoms. They get less accurate information about prevention, treatment, and prognosis, the latter being the worst in terms of accuracy. And the readability, reliability trade-off, again, we heard already that, if we had to sort of guesstimate where the average is, I think the 8th grade level is where a lot of our scientific messaging is probably appropriately aimed. Patients with rarer cancers, and I'm particularly sensitive to this, are vulnerable to the surfacing of misinformation. They can easily be sold snake oil. And then finally, and to perhaps no one's surprise, I'm not here to demonize pharma, but if you search about a specific medicine, it's going to lead you to the drug company's website about 20% of the time. And of course, that's going to give you a more favorable view, usually, of a particular medicine. Again, one that's already presumably FDA approved and available. But most importantly, I think, what do the patients find out about us? By us, I mean oncologists. So a couple of years ago, in a rather eye-opening experiment, I decided to use Google's autocomplete features. You probably know, you put in the string, for review and finish typing, Google will fill it out for you. So I put in the search string, oncologists are, and this is what I got back. Oncologists are murderers, we're evil, we're confused, we're criminals. So this is a bit of a PR problem. I'll point out, this is not even getting into research and the dark shadow that, among other things, the Tuskegee experiment casts over the landscape there. This is about what they think about cancer physicians like myself. So my point here is, and this was shocking when I first saw it, we can't even begin with the assumption that these people are going to trust us. It's all too easy, in fact, to portray us in this very, very negative light. On the other hand, I'm going to try to change the mood here. SWOG has a wonderful precedent, I think, in this particular space where we have been trying to build or perhaps even restore trust. I want to point out, as far back as 2012, which in the era of social media is a long time ago, SWOG was really interested in this. At the time, Twitter was described as micro-blogging. This is back when blogs were in their heyday, and also tweets were restricted to 140 characters in length. And this was our CCAP research-based grant renewal in 2012, actually incorporated, looking at the use of Twitter as part of community outreach. This is not a new concept. And again, this was spearheaded by Mike Fish. But a much more recent example, this is actually just from last week. Now, this is where things get particularly interesting. How do we use platforms like Twitter to promote trials that we already have? So this is 2001. This is a trial that, interestingly, to a GI oncologist, looks at olaparib plus or minus pembrolizumab in germline BRCA mutant pancreatic cancer. And this is where we have to, again, be very, very careful. These are patients that have a hereditary cancer predisposition. So an added layer, I think, of sensitivity is needed here. And we're using a public-facing platform, because Twitter is deliberately that, to promote a study. And I'll point out in a second, because you always have to think about your audience, if you actually follow the link there to swog.org/S2001, you actually will immediately encounter sort of a bifurcation where you can say, hey, I'm a patient, you can follow that route. Or if you're a healthcare professional, you can actually go and follow those links. And there is an entire toolkit down that latter avenue to help you communicate. So like Lynn was saying earlier, you don't have to invent or reinvent the wheel. There's people here, professional communicators, who have already come up with the language, the vetted language for you, which I will hope to you will make the whole endeavor feel less exploitative and less precarious. So whenever I'm communicating online, I kind of have a bicameral mind. I'm a patient physician. I always live on the front part of the hyphenate. So I'm going to invoke the Roman god Janus, who is famously two-faced. Now, when we say two-faced in English idiom, it's usually, again, pejorative, as we're talking about someone's duplicitous. But actually, we should be two-faced in the sense that our communication online is largely visible to everyone. So at the same time, you can be communicating to healthcare professionals. You can also be communicating to patients. And sometimes there's a common language there. And I keep using the word language, but in fact, I'm realizing that text is not an outdated medium, but one that is perhaps inferior in these cases to video, to pictures. One of the other things Mike Fish taught me, he said, Mark, you'll get 9 or 10 times more engagement if the tweets you write have pictures. He said, humans are visual creatures. And he was absolutely right about that. So when it came to the DE committee's work around visuals, who better to ask than our man in Hollywood, Jonathan Summers. So Jonathan, come on up, and I want you to tell this group about what we've been doing with cancer briefs and video outreach. All yours.
Thank you, Dr. Lewis, and thank you to the committee to have me speak today. So the Cancer Briefs was a project that we started with digital engagement from the beginning. It's a Hope Foundation sponsored pilot study that evaluates the effectiveness of social media and infotainment for engaging with the public about cancer clinical trials. So why do we do this? Well, 90% of Americans are on social media, 40% of Americans watch videos online daily. But, roughly 3 to 5% of patients participate in cancer clinical trials. So we saw this as an opportunity to really harness the utility of infotainment to engage with these patients. So it consists of 3 to 5 minute long videos produced in partnership with Digital Health Networks, DHN. DHN also managed the video dissemination and data collection. The videos ran on Facebook, and we utilized a video engagement campaign. When you create a Facebook ad, you have a sundry of options of what type. This is one of their native ones, and it optimizes to find an interest, an audience that uses videos. We define engagement by reach, which is how many people saw it. Retention, meaning how long they stayed, from 3 seconds and then the quarter of the video to 50, 75%, and 100. And outbound clicks. Outbound clicks on the ad was on the bottom right, as you could see, where it says learn more. If someone clicked on that, it sent them to a Hope Foundation or a SWOG website that we had the numbers on 1 month before, during the campaign, and 1 month after, so we could actually see what that change was. And I think we're going to play one of the videos, episode 3. We'll just let it roll. Are we? Oh, no, I'm doing video 1, new show about immunotherapy, cancer clinical trials, SWOG, and Hope Foundation. We targeted an audience interested in large cancer centers and built lookalike audiences. So what that refers to is we did a large campaign, very broad, and we looked for people who watched 95%. They represented the most engaged audience. That we then looked at the certain characteristics and features, such as their behavior, demographics, other things they liked, and we built an audience that looks like them, hence lookalike audience. Outbound clicks sent people to the Hope Foundation donation page. Video 2 was a meta-cinematic commercial of S1501. We wanted to see if we could increase awareness of one specific cancer trial that SWOG is running. We compared an audience that was interested in breast cancer research and breast cancer organizations. Outbound clicks sent people to the patient-facing page. Video 3, at this time, Facebook changed its targeting approaches. Now you can no longer do detailed targeting due to privacy concerns. It was more general. So it was 2 videos that were identical. One had English subtitles, the other one had Spanish subtitles. And the Spanish one, we targeted people who speak Spanish and were interested in Spanish pop culture. And in the English subtitle one, it was people who were interested in healthcare on a whole. Outbound clicks sent people to the Hope Foundation's DEI page. And now let's hit it.
What do you think about cancer?
Cancer. That word.
What does cancer mean to you?
What's the first thing that comes to mind?
Being bald and sick.
Taking my grandmother to the hospital.
Chemotherapy.
It's why I became a doctor.
Hope.
A disease that's taken too many lives.
I've been through chemo and it hits you like a sledgehammer.
I was diagnosed with Hodgkin's lymphoma in middle school.
My dad was affected by cancer. He was a survivor until he wasn't any longer. Every time I treat a patient with cancer, it's another opportunity to help somebody like my dad.
Cancer doesn't discriminate according to age,
race, or ethnicity.
And cancer affects people of color at an alarming rate compared to the white population.
According to the National Cancer Institute,
Black men and women have the highest rate of getting and dying from cancer.
The disparity isn't just in the Black community.
Hispanics have the highest rate of new diagnosis for cervical cancer.
Asian and Pacific Islanders
Have the highest rates of stomach and liver cancer,
when compared to other races,
Black men are more than twice as likely to die.
twice as likely.
to die from prostate cancer.
But we can do something about it.
We can do something about it.
You.
Can do something.
Cancer clinical trials.
The National Cancer Institute, or NCI, is a publicly funded agency of the National Institutes of Health.
That conducts many types of clinical trials.
Cancer clinical trials are how the medical community improves cancer treatment.
Trials lead to new medications, new treatments, and new guidelines for care.
every major treatment for cancer.
Was once tested in a trial.
The types of trials that the NCI runs includes treatment, screening, prevention, and supportive care.
They're done with the utmost respect for our patients on the trial.
Respect for the patient.
With certain types of cancer affecting minority groups differently.
We need trials that research this.
And people to take part in them.
Because right now, very few
minority cancer patients
enroll in clinical trials.
By not being in these trials,
We aren't reflected in the findings.
We need research
And results.
That represent everybody. Everybody.
Trial enrollment.
as diverse
as a US population.
So the medical community can find answers that speak to all of us.
All of us.
All of us.
in the Black community, there's been a long-standing mistrust of the medical system.
From 1932 to 1972, the Public Health Service wrongfully and unethically conducted the Tuskegee experiment.
Black men were misled into thinking that they were being treated for syphilis.
They actually didn't receive any treatment. People were not respected.
And people were seriously harmed.
But from this awful experiment came many of the laws and regulations.
That protect people in clinical trials today.
Today, clinical trials follow strict protocols and ethical guidelines.
They're done with close supervision and rigorous oversight.
To keep patients as safe as possible.
If we're going to improve cancer outcomes for our communities,
We need you. It starts with you.
You.
If you
Or someone you know has cancer.
Ask your doctor if there's a trial for you.
You just have to ask.
So you can help improve future cancer outcomes.
In the Black, Hispanic, Asian, and Pacific Islander communities.
For more information on how you can be part of the change, go to
So that was episode 3. Here are our results. Unfortunately, I won't have time to go through all of it. And I'll walk you through on the next slide some of the key points. But the one thing I want you to notice here was in parentheses, that is our retention rate. And there's clearly an inflection point at 25%. That represents, and you can see how low it drops, but after that, it goes up drastically. And what that's telling us is that we have an audience that's extremely engaged in this. And the amount of eyeballs that we were able to get on it, 83,000 for episode 1, for 2 is 61,000, and 3 was nearly 150,000. But some of the big takeaways from this was that 1, we were substantially able to increase research organization websites. So episode 1 had an increase of 873%. Episode 2, which is about a specific trial, we increased viewership by 41,300%. And for episode for 3, it's 3,682. And it's very promising for infotainment use in this manner. The other takeaway was video correlation does not equal outbound clicks. Completion does not correlate. So completion was just 652 for the whole project, but we had 2,525 completions. What that tells us is the audience is getting it way quicker and they're deciding way sooner if they want to watch it or not. The video 3 actually had the best engagement, and the Spanish subtitle video outperformed the English subtitle by many, many metrics. But one is the reach. It had half the reach, but equal clicks. It also had a greater completion percentage and the best of all the videos that we showed. And it really speaks to the importance of cultural tailoring and how language concordance could really help to attract a diverse audience into our trials. The high attrition, again, 99.3, 99.5, 97.2. The average Facebook watch is 4 seconds. They suggest videos under 15. Our videos are about 5 minutes. So it really illustrates the challenges of getting using infotainment and getting people's attention and keeping their attention. But if your project goal is not to have video completion, then outbound clicks is a very reasonable way to approach this. Talk about that. And next steps, we wrote a manuscript, Dr. Vita Henderson from Fred Hutch. The utility of social media and infotainment combined with digital marketing analytics are promising strategies for clinical trial enrollment. We completed the manuscript with Dr. Henderson. We are applying for future grants to expand upon this pilot, and we welcome any opportunities for collaboration with you guys. And thank you for having me today.
Thank you so much. So we're gonna have time for questions and answers at the end, and we have one more person to present, and I'd like to introduce Adriana Carrington. She is a clinical research coordinator for the Gibbs, at Gibbs Cancer Center and Research Institute, and she focuses on the Cancer Moonshot Biobank Research Protocol. Her work entails promoting the participation of underrepresented groups in the Cancer Moonshot Biobank, working with patients to identify barriers impacting cancer control and cancer care delivery, as well as educating patients and families about research and access to adequate care. Adriana leads the Gibbs Cancer Center and Research Institute's Community Advisory Council, which is comprised of community members and healthcare providers. And I have the pleasure of working with her as well, and I'm really excited to hear about her presentation.
Thank you, Kamara, for that introduction, and thank you to the SWOG team for inviting me today. Okay. I can go through these. Would you like me to? Okay, so we're going to go through a few poll questions before I give my presentation. So the first question is, does your site have any of the following? Select all that apply. So a community outreach team, communications team, or any other team you utilize to talk about community engagement?
So it looks like we have communications team and community outreach team are the most used. So
Okay, great.
we can go to the next one. I think there's one more question.
Okay, does your site have any of the following internal resources? Patient navigators, patient materials, cultural competency training?
So it looks like the majority have patient navigators and patient materials, and many have cultural competency training.
Okay, that's right. All righty, so today I'm going to be giving a little bit of practical approaches about community engagement at our site. So the Gibbs Cancer Center and Research Institute is housed part of the Spartanburg Regional Healthcare System in upstate South Carolina. And we have 4 cancer center locations located in upstate South Carolina. And we serve many counties, 4 counties in upstate, as well as 2 counties in North Carolina. And we see about 3,000 analytic cases a year, which includes serving a large rural population. So for background information, my role at Gibbs Cancer Center stems from our site applying for an engagement grant through the Cancer Moonshot Biobank Protocol. And with this engagement supplement, we apply to enroll and engage African-American patients with cancer onto the biobank, as well as develop a community advisory council, and to increase physician and patient engagement, as well as develop my professional career in clinical research. So today I will discuss key elements of community engagement at our site, and we will focus on the importance of diversity in clinical research staff, education, partnerships, and developing a community advisory council. So to start off, you want your clinical research workforce to represent your patient population. I always talk about this at our site and with community sites. You want to start recruitment with your local schools. So for example, prior to me joining Upstate Carolina NCORE, I was a graduate student at Furman University. And my program focused on community engaged medicine. So when I applied to work at this site, this was the perfect job for me because I had already been participating in the field. And I got the opportunity as a person that was not in a traditional RN background in clinical research. And I got the opportunity to train under oncology certified nurses and go to training courses and figure out where did my role fit in clinical research. And that is a true key to expanding your workforce. So for education for your clinical research team, I think it's important that you need to start with your leadership. So at our site, our manager and our director and our leadership team participated in equity and economic mobility sessions where they attended to focus on different community outreach sites that we needed to come together and figure out how to better engage our community and enroll patients. Excuse me, may I have some water? Thank you. Oh, thank you. Thank you. And to better focus on how we can increase our clinical trial participation. Also what's important, you would need your staff to participate in DEI training. So diversity, equity, and inclusion is a huge part of your research staff being comfortable working with patients from different backgrounds. So one of our proud moments, we have worked with the Bookers who own a consulting company called One Acorn. And the One Acorn Consulting Company is owned and operated by lifelong residents of Spartanburg, excuse me, who have deep ties in the community. And they have worked with us for 3 years to build two-way partnerships between our patients and our survivors in our community. Sorry, my apologies. And they play a vital role in our advisory council. So through the Bookers, we have formed internal and external partnerships. And today, I think it's important to spread around that at your sites, from an internal point of view, it's important to work with your outreach department. So at the Gibbs Cancer Center, we work with our diversity director, as well as different foundation leaderships to figure out what are we doing and how can we be better to get our patients on trial. As well as we recruit clinical research students from different schools and universities and local churches and barbershops to figure out what are our patients need in the community and how can we provide better care. And I'm so sorry. And we work with different federally qualified health centers in our community that see patients who may not have insurance and how we can provide access to cancer-related resources. And we do this because we're doing the work in the cancer center, but how are we supposed to know if our work is effective for our patients who need to be on trials? So one of our biggest accomplishments of community engagement at our site is our Community Advisory Council. And our council is pretty much the glue of what holds clinical research, the clinic, our patient and providers together. So the council is led by myself, our medical director, Dr. Amy Curtis, and one of our physician champions, Dr. Tondre Buck at Spartanburg Regional Healthcare System. And this council is comprised of patients, survivors, community health nurses, outreach staff. I mean, we have a huge support system to figure out how can we better provide access to clinical trial in our catchment area? And we could not have formed this council without the work of the bookers, as well as without the work of our internal or external partnerships. I mean, connections through VPs of organizations, the schools, a lot of our council members own barbershops. I mean, we are very grateful for the work we're doing and to have all these connections. And this is our third year having this engagement council. So as Lynn talked about, we want this work to continue. It's not a one-time meeting thing. We meet 4 times a year and we figure out how can we get screenings to our patients in the community? How are we effectively implying community engagement at our smaller sites? What social determinants of health are impacting our patients to have access to clinical trials? How are we utilizing our educational materials for clinical trials? You know, are we maximizing every effort to talk about clinical research? As we've stated, some people know about research, but do people truly know about clinical trials? Do people know about CCDR trials? What is the difference, especially with Moonshot? That's a biospecimen study looking at drug sensitivity. Most patients need to know about that, but how can we better provide the education materials? So this is a snapshot of our council coming together at our yearly CAC retreat. And we come together in person once a year. So we meet quarterly, but towards the holidays, we get together and our physicians give case presentations to indicate how our community engagement is impacting our clinical trial participation. And from a Moonshot standpoint, we are very proud of the work that we are doing at Upstate. And we know if it was not for forming this council and it coming out of that supplemental engagement grant and supporting my position, this could not be possible. So we are very grateful for that work. And again, we could not do this without our external and internal partnerships. As you can see in the picture to the far right, we were all kind of bundled together, spending time with each other, going over our yearly review of the work that we've been doing and truly indicating that you cannot effectively do work in clinical trials if you do not have trust between clinical research, your physicians, your advocates, and your family. And the key thing, always remembering your why, because at the end of the day, we all do very hard jobs and we get really frustrated. And we know, especially at SWOG, that data is very time consuming. Seeing those patients, making sure they're coming in for their follow-ups is very frustrating, but we're doing this to provide better care for our patients. So to quickly recap, I'd like you to take away these key points. First thing, ask every eligible patient to participate in a clinical trial. The worst answer is no. That's how I approach it. You can only be told no. You may receive a maybe, but at the end of the day, at least you tried. Engage your internal and external partners. You know, always be comfortable with being uncomfortable. Prime example, me today speaking. Examine your own implicit bias. We all have it. We're human, it's normal, but make sure you turn that off before you have a conversation with a patient because you do not necessarily know their story, their background, their family, where they come from. Maximize every invitation to discuss research. It's very important. I mean, we have conversations just simply being in the barbershop, being at the nail salon, being in the grocery store, whether you're going for your screenings for your colonoscopy or your mammogram. Talk about research at your site, talk about trial participation, get the conversation going, learn the different perspectives from different cultural backgrounds. And last but not least, again, always remember your why. Thank you.
Okay, we have plenty of time. If anyone has questions, we're happy to have more discussion. And I will just share my little piece of community engagement. Sorry, I feel like I'm having a little feedback, but I actually told Adriana that when I was I got a mammogram, I think a few months ago, and I was sitting there in the row with lots of ladies, and somehow we started talking. And I said, oh, we have a TMIS protocol, and we have other protocols. And no one knew, surprisingly, of the room of 5 ladies that we had research. I said, oh my gosh, yes. And I gave them all the information. And that was my, like, I know that was something simple, but I'm telling you, I've enlightened 5 more people that we do research and how important it is to engage. And I will say for our site and having Adriana there, I know not all sites have the resources to have someone that's dedicated to a particular protocol. But just learning your internal resources, that was a game changer for us. We didn't even know, like our diversity person who focuses also on translational services, she knew research, but now she really knows research. And when we ask for support, that person is there and that department is there. And having the foundation within our hospital system be more aware. I mean, they plug research as much as they can to help support the initiative. So I just think like we didn't have those connections even internally, and we're all under the same umbrella, but sometimes you're working in silos and you don't know who's at the next department. So, you know, community engagement also starts with your internal community. So just throwing that out there, but we'd love to have some questions, and you might have a question. Noted.
Do we have questions? I actually have a question for Dr. Lewis, and it relates specifically to Twitter. And I mean no harm with this, but I've noticed such a change in Twitter over, you know, the last year, and really amplifying lately. And I just wonder if you find it as valuable as you did.
Yeah, this mic's sorry. Yeah, and I probably made my presentation, or at least my own comments, a little bit too Twitter heavy. So I anticipated a question like this. No problem at all. I think one of our messages actually was to be a little bit platform agnostic, and I'm well aware that Elon Musk is not exactly the most stable of leaders of that particular platform, and its days may be numbered. And conversations on there have become increasingly toxic, I think is an appropriate word. But even before the atmosphere became more vile, I think what's important to realize is patients were, and it was interesting to see the polls earlier, patients were seldom the audience I was interacting with on Twitter. I got a lot more engagement from colleagues. And again, it was fascinating to see the reason that many of you use social media is to do exactly that, to professionally network. So again, whether it's Twitter, we had a long talk in our DE committee today about Facebook. I think it's important to think about, well, where are the patients? If you don't mind, I'm going to pivot and talk about Facebook for just a second. Really the thrust, or one of them, of our DE committee meeting today was that for all the problems with Facebook, whether it's Cambridge Analytica or some truly egregious leaks of patient data around BRCA in particular, that's where a lot of the patients still are. And in my patient life, I've co-led a Facebook group for patients with rare tumors since 2009. And I've seen, I think, 2% attrition in our membership with all of the concerns around privacy. And so again, if you're thinking about, well, where are the patients? A lot of them are, you're right, not on Twitter. And then where I really feel like an old man is my kids tell me all the time, Dad, Twitter is not where it's at, it's TikTok and YouTube. And so I think being agile, and as Jonathan showed us, being thoughtful in regard to video engagement, I think is extremely powerful. So last thing I'll say is, yes, my experience has changed. I think I have a pretty significant sunk cost fallacy, having been on the platform since 2012. I think the last year in particular has made me more concerned than ever about its durability. So I would not be married to Twitter if you're interested in promoting a clinical trial.
It's interesting because I don't get on Facebook, and the only reason I ever even got on Twitter is, funnily enough, because you spoke one time at a SWOG meeting, and I can't remember how long ago it was, but you talked about all the information that was shared with colleagues, and I thought, well, that's just fascinating. And then what I liked about it is that I can follow writers that I respect, that I read and see what they have to say. But lately, it's hard to even find the people who I follow.
Yes.
So I fear there's so much disinformation out there, and I just see it so amplified. And it, you know, I just wish that something popped out and said, this is a big lie, and here's the truth.
There is a little bit of a corrective, and again, I'll be a Twitter apologist here for just a second and say there's something called community notes now, where it's crowdsourcing exactly that sort of fact verification, but even that is a a small antidote against a large problem. Also, to speak to Facebook within SWOG, many of you might remember we ran an experiment. We're clinical trialists. We ran an internal SWOG Facebook group that was a huge disappointment. And I think it's important that we acknowledge that Facebook was not the medium, not the platform for most of us. And we tried using that for internal comms, and it just, as Frank can also attest, was not of interest to many of you. And I get it. And I think even in our lives, and you were asked earlier, how to use social media professionally, I think Facebook more than any other platform probably blurs the line between personal and professional. As Frank also mentioned, a lot of people think of Facebook as a sort of early adopter place that you could share information with friends, but not necessarily as a place for serious work. And I think the other thing we learned from this poll we just took is LinkedIn has a lot of professional gravitas, if that's not the wrong word. And you're right, Frank, maybe we need to be thinking more on the DE side, at least internally, LinkedIn.
Lynn, I have a question for you, and I wanted to thank everybody. Excellent presentation. But Lynn, I was really struck by your remarks, particularly related to supporting your community partners. You talked about purchasing a table every year. If you could talk about some other examples and also speak a little bit more about the long game. I think a lot of people think you can drop in and drop out. If you'd comment on both of those. Thank you.
Sure. And thank you for the question. One way that we support our community, for example, we work with a federally qualified community health center called Hope Clinic. And I was actually one of the founding members of that clinic. And because I was on that founding board, I was able to get the clinic really excited about opportunities to do research. And so in addition to serving on the board for many years, I bring in my team, we sponsor tables, doing fundraising, we bring in research. And one of the key pieces of research that we facilitate this research relationship. So we will tell our researchers, when you're writing your grants, build in the funds for working with the community. For example, if you want to recruit participants at Hope Clinic, and it's extremely diverse, if you want to recruit participants, then you have to build in funds so that you can allow them to allocate staff members to help you accrue, to help that you track, document, record data. And, if you're getting a $500,000 or $1 million grant, what you might want to do is build into a subcontract with that organization. And over time, what we've done is we build in, let's say, a $50,000 subcontract or something like that. And they can use it to pay for their own research coordinator. So then they always have a research coordinator that we've trained. So then we can, when we work with them, it's so much easier. We had a researcher that did a liver study with the clinic, and they recruited 1,000 participants. That's a lot of people from this clinic to assess potential risk for liver cancer. And as part of this study, the researcher was able to get a company to donate a FibroScan to the clinic. That's like $100,000 machine. And now the clinic has this machine. They receive training to know how to run the machine. So this is, it's continually building on our partners' capacity to do research. So there's so many opportunities. So my team often serve on boards, advisory boards for other community organizations that we have long-term relationships with. We support, for example, Komen. We help them accrue healthy women to give healthy breast tissues. And that's really hard to get, African-American and Hispanics and Asians who are healthy to go in to have an invasive procedure done. But we were able to help them reach and exceed their goals because, we have all these connections and they know that they can count on us. So then when we ask for help, it's always sure, whether it's a letter of support or whether it's helping us accrue participants. Our community partners are just as committed to us as we are to them. Thank you for the question.
So I don't have any questions on the chat, and I invite anybody else that might have a burning question to come on up. And I think, Allison, you may have had a question or two. Oh, okay, we have someone coming up.
Hi, agree. Great presentation. Also in the Mark Lewis fan club, started following you on Twitter after I saw that conversation or the presentation you did. But question in regards to the advisory board that you guys have at Gibbs, and it was really interesting because you have the full spectrum. Like you don't just have the cancer center, you're engaging other areas within your healthcare system. How did you do that? And can you share the ways, like how did you start bringing people to the table to get them excited about it?
Well, honestly, that stemmed from our partnership with our consultants, the Bookers, who own the One Acorn Company. So they have deep-rooted ties in our catchment area in Spartanburg. And Dr. Russell Booker, he sits on a lot of boards. So he connected us with VPs of organizations, and our managers and leaderships had like one-on-one meetings. And he was a part of the vision when we first opened our Cancer Moonshot Biobank study at our site. So we've had this from the beginning. And then he connected us and we formed two-way partnerships, and then we connected with other people, and then it continued on. So that's how it has expanded that way. And we're very proud of that work. But I would recommend starting with someone close to you in terms of an internal partnership, or if you have someone close to your site that's an external partner, and kind of build from there. Give information about your trials and the work you're trying to do, and start small and then go from there.
Feel so often that when you're in a community setting, we talk a lot about treatment and treatment of the patients and supporting them when they're getting their treatment, and how do we improve their life when they're getting treatment. But we have prevention studies, but we can struggle with them because it's trying to connect all the dots with that. So how do we find the way to get people excited about it from the get-go, and then have that as part of that whole advisory? So I applaud you guys for being able to do that. It's very cool.
Thank you. Thank you for your question.
If I may add to that, pre-pandemic, we always treated our advisory board like royalty, because we know that dedicating time and resources to come and help us and give us the expertise. So, when they came in, we always had a big spread food for them. We sent them appreciation certificates. We were always, thanking them. They knew that they could get any questions answered. If we didn't have the answers, we could connect to them, because we want that support to be two-way. After the pandemic, when we couldn't meet in person, we showed them how to use Zoom. We actually did a lot of training for our community organizations on how to use Zooms, so that they can get teams together. And one thing we also started doing is we started compensating for their time. For some studies, we would say, if you can attend for each meeting that you can attend, we want to really recognize your support and your effort and your time. We want to be respectful of your time. So we might have a nominal fee, like $25 or $50 per attendance. It depends on how much money that, the group had put aside. And that's what I meant by putting money aside in the research, so that you can provide this kind of support, because you're asking people to take time out from cooking dinner for their family or helping their children with their homework, really just appreciating their time. And sometimes we've actually even ordered food for them and sent it to their homes, so that they can participate on Zoom and still have, something to eat.
Yes, that is something I agree with that.
I am Rick Bangs. Until Sunday, I am the chair of the Patient Advocate Committee. So I wanted to ask a question and kind of frame it from the perspective of a study chair or a committee chair here at SWOG. Those folks have no control over the sites directly. All right, so if I ignore social media, which is not because it's not important, but because it's going to be like the easy answer to my question, are there 2 or 3 things that this group thinks the study chairs or the committee chairs ought to be considering or asking to ensure that there's effective community engagement?
I think that, and I can go first. I think I know you have no control over the sites, but you really have to have a handle, an understanding of, and when a site signs on, what does a population look like? What is your pool of eligibles? Don't look at risk incidents, because incidence only tells you, how much risk that one population has. It doesn't tell you how many people can you expect to see and what will those people look like. So, if you have, and that's why for Texas, at least, 60% of prostate patients are white, and African Americans comprise only 10% of patients. And that's because the older population, the populations that's 39 and older, are more white, and the younger populations are more diverse. And so again, the older you are, the higher your risk for cancer. So it's going to reflect by the age. So you really want to know what that pool looks like, so that you can at least have some idea about what your recruitment goal should be, to make some feasible and attainable goals.
I think also it's probably beneficial if we take advantage of our community advocates.
I was hoping somebody might mention that.
Go ahead, talk about it, Rick.
Yeah, so we have community advocates, some of whom are in the room, I suspect, somewhere. And so they were put in place to make sure that the voice of some of the underserved communities are represented here at SWOG. So our research advocates, as many have probably recognized, are not representative of the patient population historically. We've made some improvement there. And so we included race and ethnicity and sexual orientation and rurality and metastatic state and caregivers. That's the vision, right? And there are theoretically 10 people who are funded to be in this role. So we've had some challenges in terms of turnover. There've been some health issues, but also in terms of like defining the role of the community advocate and embedding it into the process. So study chairs and committees. And so my replacements, we had two, but one has left the room. All right. So my replacement, this is what the PAC will be contending with, is trying to wrestle this to the ground. Because I think community engagement is so critical to improving diversity and representativeness. And yet SWOG has this kind of hands-off relationship with the sites. So we don't control them. We don't tell them what to do. On the other hand, in order to deliver the diversity and representativeness, we have to respect the fact, as Lynn's pointed out, that the sites who activate the trial drive the diversity and representativeness that you get. So, some a little bit more intentionality around the sites and looking at the sites you've got and what they're going to deliver. And of course, engaging patient advocates are the community advocates is certainly something to consider, but there may be other ideas, but those are good ones.
Rick, did you want to mention the community advocate networking event tomorrow?
Oh, yes. Thank you, Frank. Thank you, Frank. It's just an excellent lead in. Okay, so two of our community advocates are hosting a session tomorrow. It's on the first floor at the American Craft, I think it's called. All right. So the community advocates are Lauren, who is AYA, and Joelle, who is LGBTQ+. All right. So they're hosting it. So I would look at this and think about this in terms of, do we have affinity groups or identity groups? I don't know what your favorite term for it is. I know Allison and I have talked about it, affinity groups. I've heard identity groups. But for these communities, we don't have that here at SWOG, right? And so this, to me, I hope is a catalytic event. So it's at 5:30, is that correct? 5 to 6:30. I knew there was a 30 involved. So 5 to 6:30 tomorrow. Please make an appearance. You do not have to be a member of either of the two communities Okay, so they are looking for people who are interested in that, includes allies, and I want to make a push for allies being part of this process. So thank you, Frank, for the lead in. I was trying to figure out how I might finagle that in, but you gave me the foot in the door.
All right, thanks, Rick. And so I have something that's probably more both a question and a comment. I think the question is, to what extent do your sites actually have the PIs of the study go out and do community engagement? How successful is it? And how do you train the PIs to be able to engage with community at an I think we're talking about 8th grade level. So I'm curious about that.
I can start. So our PIs are very involved and I stay on top of this as well, but they actually go to community health events, local health clinic fairs and local breakfasts with the hospital to talk about research and to talk about the advisory board and the work we're doing. They're also involved with how we are doing with our demographics for each patient that we put on trial. What can we be doing better? So they actively communicate with us and our patients in the community as well. They're on our board, as I mentioned on our slide, so they attend every meeting and they're also involved giving presentations, asking questions, answering questions from our caregivers and our ambassadors on our board. So very much involved at our site.
And did you have to do any preparation with them
Well,
to go out into the community?
Not from my end. I think our leadership participated in training with them as well, but from my end, no.
Okay. Thank you.
As a coordinator.
I would add also that when we've invited our researchers to come out into the community, we always offer to review their slides. And this came about after one of our division heads came out into a community meeting and brought along 80 slides. So now we review and we say, maybe 5. And then we review that and we make sure it's in plain language and it's like, what are the key points that you want to bring across?
Thank you.
Hi. So I'm at Ascension in Wisconsin and I'm a part of the Crown Consortium. And I was actually just talking with someone about physician engagement and how difficult it sometimes is to get our physicians excited about participation in NCORE trials and NCTN trials due to these RVU models for physicians. And it's totally understandable because if they have to have high patient, volume, how can you then say, okay, now you have to take the time away from your family, your friends, your personal life to set aside for research? So we're trying to find ways that we can partner with our service lines and that we can partner with our organizations to talk about the return on investment, if you will, and have some administrative time set aside for them to participate in research. But this is a struggle. So there's a lot of excitement. There's a lot of interest in research in general, but like I said, NCTN and NCORE trials are just not that exciting from the standpoint of having to sacrifice something, sadly.
Thank you. I think that's definitely a relevant, these are definitely relevant concerns. That time that you're conducting research is not, it's seen as something that's taking away from contributing to those clinical hours that you're required to do.
And I'll just add at our site, we do have leadership that focus on research and also recognize the model of paying an investigator for their time is not always available, but we do recognize physicians within our team that have gone above and beyond and have gone to leadership and said, can we have 1 day a week or 4 hours a week that are, specific for research so they can have more support. And we've received that support from leadership. So I'm not saying it's an easy path, but I've gone through a lot of business cases to say, hey, what does research do for our site? outside of the, the Commission on Cancer Accreditation, which of course we're a big role, that plays a big role. So there's other things you can do, but recently we even had our, I think they were looking at like what you do as far as community service. And we had a big leadership meeting where I think there were probably about 400 people from our healthcare system, and research was mentioned and about the great things we do. So I keep on saying, like, I know we need to go out in the community, but internal, especially in Spartanburg, where, our healthcare system is also serving the patients that work there. We employ, I think we're the biggest employers there in that county, one of them. So we're fortunate to be set up that way, but I know it's a difficult road to get the investigators with more time. And I think we have a question.
Yeah, so thank you. Really enjoyed all of your presentations, and your work should be applauded. I mean, it's not easy work, and each of you are doing really great work. My question is, my name is Hildy Dillon, and I've been an advocate at SWOG for many years. I'm also rolling into an emeritus role as of Sunday as the patient advocate vice chair of our committee. To follow on to Rick's question, because we're always told we don't have much control over the study sites, because the advocates are very keen to point out that patient-clinician shared decision conversation that could make or break enrollment in a trial. Are we inviting everyone that could possibly be eligible? So are there things that we could do or collaborate with you as the advocates at SWOG that are engaged? SWOG has really embraced advocates in protocol development for the most part. Are there things that we can be bringing up about community engagement in the development of these trials that would make it easier for you? Are there things that we do that make it more difficult? And if we're saying, if we really want to diversify the accrual here, we need to listen to the experts that are doing this well in community engagement and incorporate certain strategies into the trial development. So if there are things that you can think of that we can bring to our committees that would help you, we would love to have that conversation.
I think one of the things that I always talk with our faculty when they're developing research is, once they're at MD Anderson, Joe Unger also had this wonderful research that he published about the barriers to participation, and basically 75% of the barrier is structural, is people are at a place that did not have research. And then when it did have research, they didn't have the research for whatever the condition they had. So a much smaller percentage actually were offered research opportunities, and then a smaller percentage said yes. So what you want to think about is if they're already at your facility and you have the research. So, this is actually a smaller population. So you want to make sure you're not missing anyone. You want to make sure you think about your research. You might want to get feedback from your patient advocates beforehand and ask them, have we made it easy for people to say yes? What in this protocol might make it hard for people? So do we understand our patients? Do we understand their lives? What does that look like? What are these potential barriers? And really, if you have to build in money for a Lyft or an Uber for them to get to the hospital, it's going to be a lot cheaper than you not being able to complete your trial because you can't get them to come in because of transportation issues. So, I mean, I would say think about those issues and talk to the advisory members beforehand. And so build that into the trial. And always uppermost in my mind is, have we made it easy for people to say yes?
Lynn, that's a perfect point. This allows me to give a plug for Pragmatica. Pragmatica is a novel design, really stripping down and making it easy for people that do have that stage and disease. And I do think that hearing advocates talk about transportation, well, if we have unnecessary visits just to benefit the protocol and not to benefit the patient, that's a huge barrier. And I think that can't be stressed enough. And so if you haven't got Pragmatica open at your site, it is an amazingly stripped down, easy study that will allow your patients to have novel agents to treat progressive lung cancer. Thank you.
Hi, this is Irene Tami. Fantastic presentation from all of you. There has been a lot of talk about the recruitment process. I'm wondering if in all these opportunities through the SWOG trials, there has been profound and deeper analysis on the disparities in terms of retention. Who are the groups who are out faster? Who are the ones who remain, who are the ones who need more support in terms of age, gender, identity, sexual orientation, race, ethnicity? So that's my question. Thank you.
I think that's an important part of this, because if you lose your participant halfway the trial, then the trial also doesn't get completed. I think that those are definitely relevant and important questions. I'm not sure if Joe Unger might have some answers for us on that end. So we'll have to probably ask him a little bit more about that in terms of having that follow-up about retention.
I would just say, as far as the retention, sometimes it is specific to the site and the relationship that was built with the patient, the physician, and the research staff. And we've heard lots of tips and tricks about calling the patient, making that connection, doing reminder calls, and some coordinators can act and help facilitate the care of a patient. And I really think that, we've had coordinators invited to weddings. There's amazing relationships that are developed with research staff, and sometimes it could be specific to that person, right? But we'll have to take that question and research it, because it is a great question, like, who's staying on and who might be dropping off.
So if I could just tie back to the question. So the kind of visibility, transparency around the accrual data has probably not been as good as it might have been. And so there is some data floating around. Some of you in the room are aware of that. And the data, some of that data has been leveraged by our DEI champions, who have done a little bit of digging on a couple of studies relative to retention. I think, Lucy, you did some, and I think, which one? Colmar. All right. So the first step in this is having some data, having it accessible, and at the right level of detail, right? The study level, the institution level, and having the the demographics and the age and whatever your criteria is for doing the analysis. So there's some early work being done in this space, but there's way more work that needs to be done.
Just wanted to add that that piece of information will be important, because you will want to think about perhaps oversampling certain groups, because you know that you will miss them later.
That's key. Great. I don't have any questions online, so I don't know if we had any more questions.
All right, well, thank you everyone for this, for joining us for this wonderful session. And also, can you fill out the purple sheet so that we can keep track of feedback? So thank you, everyone. Have a good rest of your SWOG meeting.
Thank you.